Hello and welcome everyone to this very important session of ENT, where we are going to discuss the previous year questions from NEET PG as well as from INICET, which was at one point in time AIMS and different central institutes, which has become INICET now, plus NEET PG. We are going to discuss all of them in this session. We have 1 hour sessions. Let's see how many of these we can do. And if you have any questions, you can ask me on the YouTube channel. I'll try to answer. So I've mixed all the questions. I've not gone year by year. So we have done what? We have mixed the questions. Okay. Now the first question. A patient has undergone canal wall down mastectomy for the treatment of cholestoma, which led to enlarged meatus. Now tell the name of the surgery procedure which involves construction of the cartilage part of the external auditory canal. Is it canaloplasty, myringoplasty, tympanoplasty, or meatoplasty? What is it? Now I'm sure you have heard of mastectomy. Everybody knows about mastectomy surgery, and also we know that mastectomy surgery has subtypes: canal wall up and canal wall down. So this surgery is about canal wall down surgery, as it says, which is done for cholestoma or unsafe CSUM. So the reconstruction of the cartilage part of the external auditory canal, which is done at the end of canal wall down surgery. What is the name of this surgery? It's a very popular question. It has been asked few times. And the answer is meatoplasty, repair of the meatus. I'll explain this. Right. Now, myringoplasty is repair. Myringoplasty is repair of the tympanic membrane, which is done for safe CSUM, and tympanoplasty is repair of the middle ear. Tympanum is middle ear. Now, so which is also done for safe CSUM. Now, when I draw the, if you have attended my lecture, you'll know that when I draw the canal, this is the ear. Right, this is middle ear and this is inner ear. Okay. Now this is canal, external auditory canal, and this is meatus. This is myringus, tympanic membrane is myringus, and this is tympanum. See, it's so logical. If you do the repair of the meatus, it is meatoplasty. If you do the repair of the canal, it is canaloplasty. If you do the repair of the myringus, it is myringoplasty. And if you do the repair of the tympanum, it is tympanoplasty. Now, if you know the anatomical names, you know that this surgery is which part of the ear. Okay. So, when you repair, see, I'm also sure that you know ear has two parts. If I draw a line here, this is the bony part of the ear, and this one is cartilage part, and it clearly says you are doing the repair of the cartilage part of the external ear, which is meatus, isn't it? So the surgery is meatoplasty. You repair the canal. Now meatoplasty is done after two surgeries. It is done A, after radical mastectomy, and B, it is done after canal wall down mastectomy. Canal wall down mastectomy, and both these surgeries are done for cholestoma. So clearly, this surgery was canal wall down, as they mentioned, and they are telling you that you are repairing the cartilage part of the external canal. So it is meatoplasty. Is it asking, Ganesh, I did not get your question. You are asking me, is it asking how we repair the PT tube? What is PT tube? It is not talking about the PT tube. It is asking about the cartilage part of the external auditory canal. It's not about, I think you want to say ET tube, station tube. No, it is not about station tube. cartilage part of the external, clearly written here, auditory canal, which I told you is this part, and this part, as I said, is called meatus. So the surgery becomes meatoplasty. This is very basic, very conceptual, and it's a very interesting question. It was a very nice question actually. This was asked in the exam. I think it was last year. Okay, off to next question. A patient of 25-year male came to AIMS OPD presented with fever and difficulty in swallowing. On oral examination, the following observation is seen as in below image. Diagnosis: is it peritonsillar abscess, parapharyngeal space abscess, retropharyngeal space abscess, and Ludwig's angina? Right. So what is the answer? Good evening, Avinash, after a long time. Avinash, so nice to see you and hear from you. So what is this? What is the image showing you? The image is showing you the oral cavity and oropharynx, isn't it? Oropharynx. This is the soft palate. And these are the tonsils. And the tonsil of this side, you can see this tonsil is enlarged and pushed medially. So when the tonsil is enlarged and pushed medially, you have either tonsillitis, which is the most common cause of enlarged tonsil which is pushed medially, quinsy, which is peritonsillar abscess. These are the two common causes, and very rarely parapharyngeal space abscess. Parapharyngeal space abscess may push the tonsil medially, but it will not cause the enlargement and the congestion of the tonsil, because parapharyngeal space abscess is not the disease of the tonsil per se, isn't it? But rest of the two is not possible. Retropharyngeal space abscess is behind, retropharyngeal is behind the pharynx. The problem is here, in the bulge is here. So this cannot be possible. And Ludwig's angina is a cellulitis of submandibular space, this area, submandibular space. So this is not possible. And parapharyngeal space is not possible because I said parapharyngeal space may push the tonsil medially, but it will not cause the congestion of the tonsil. It's not an inflammation of the tonsil, and therefore peritonsillar space abscess, which is also called quinsy, is the only possible answer. Right. Most of you got, everybody got it right actually. Next one. A 20-year-old female was moving towards her home by two-wheelers. Suddenly she fell down and had a fracture of the middle cranial fossa. Identify the sign shown in this image: battle sign, Bayard sign, water sign, and Gray Singer sign. What is this sign? As you can see, there is a face, ear, and the mastoid area, and you can see there is a bluish color of the area, and they are very typically telling you very clearly there is fracture of the middle cranial fossa, and the fracture of the middle cranial fossa causing bluish color of the mastoid area is battle sign. Yes, everybody got it right. Gray Singer sign, very rightly said by Avinash, is seen in lateral sinus thrombosis, and in this there is edema. There is no black blue color like this is blue, yes or no? But in Gray Singer sign there is edema, in this there is blue. And Bayard sign is seen in laryngocele, it's a swelling in the neck. And water sign, there is no water sign but water's view, which is X-ray view. We have question on that also. Right. Next one, let's see. Tuberculosis otitis media is characterized by all except. Very simple question. Last year question it was. Painful otorrhea, multiple perforations, pale granulations, and foul smelling discharge. So which is not a feature of tuberculosis of the ear basically? What is your answer? Yeah. A. Tuberculosis is painless. It's a very, very important point. There is no pain of the ear in tuberculosis. It's a painless disease, and therefore A is a correct answer. It is not a feature of tuberculosis. Yes, very important. These two are very, very important. MCQ, they ask you so many times these two special features of tuberculosis. One is multiple perforations and the other is pale colored granulations. These two are extremely important. Very commonly asked, these two. Right. And yes, discharge may or may not be foul smelling, not always foul smelling, but it is possible to have a foul smelling discharge. Next one. Again, last year's question. A child was brought to a doctor with X-ray with a complaint of barking, cough, fever, hoarse voice, noisy or labored breathing. typically worsens at night. The X-ray is given, shows stipple sign, therefore the probable diagnosis. It's so straightforward question. The whole history is useless. They have already told you it is stipple sign, and we all know that stipple sign, even if you cannot identify the X-ray, where you can see there is a narrowing of the airway at the top, like this, which is called the stipple sign of pain, also called pencil tip sign, is a feature of acute laryngotracheobronchitis, which is also called croup. So very simple. I think 100% of you will get it right. I'll answer your question, Ganesh. Let me finish this. Acute epiglottitis has thumb sign, and laryngomalacia has omega shaped epiglottis, isn't it? And laryngeal wave, there is no such sign as such. Okay, so it's stipple sign, therefore it is acute tracheolaryngobronchitis. Red granulations. See, talking about granulations, Ganesh, you answer your question. Talking about granulations in ear, in granulations in external auditory canal, doesn't matter what the color is, it is usually red in color, of course, is diagnostic of malignant otitis externa, and granulations in middle ear, whether it is red or pale. Red granulation is seen in unsafe CSOM, and pale granulation is seen in tuberculosis of ear. So this is all about granulations that you have to know in ear. All about granulations that you have to know in ear is this. Okay, and it's very useful. It can be really helpful. If you got polyp in the ear, polyp, pale polyp or red polyp. Pale polyp is safe CSOM and red polyp is unsafe CSOM. So these are, no, in keratosis obturans you usually don't see granulations, no. No, granulation in keratin obturans. Okay. Next question. Occipitomental view with open mouth view to check for nose and pharyngeal sinus is what view basically? Is it Waters view, Cardwell's view, Towns view, or Pierre's view? Before this question was asked, this is 2019 I think, or 20. Before this question was asked, nobody knew this answer. Almost 100% got it wrong when it was asked, despite the fact that I used to teach in my lectures. And this is Pierre's view. Pierre's view is occipitomental view. Occipitomental view if it is open mouth or closed mouth, and it clearly said is open mouth. So this one, this is Pierre's view, and closed mouth is Waters view, as Avinash is telling us. Avinash, thank you for informing. And Cardwell's view is a simple AP view with only 15 degrees angle, and Waters view is for mastoid. Towns view is for mastoid. Waters view is this one, isn't it? PNS. Towns view is for mastoid. So these are the important X-rays of ENT that you might want to remember. Next one. A patient came to ENT clinic with symptoms of crusting in nasal cavity, nasal obstruction, nosebleed, and patient also told the doctor that his wife sleeps away from him because of strong foul smelling coming from the breathe. Now, doctor advised him for partial closure of nasal orifice. Done in which condition? This is done in which condition? Is it atrophic rhinitis? There's so many hints in this question to make a diagnosis. Chronic fungal aspergillosis, vasomotor rhinitis, fungal mucormycosis. It's very clear. Even the presentation, crusting, obstruction, bleeding, foul smell from the nose, isn't it? These are all very typical of atrophic rhinitis. And atrophic rhinitis, which has many types of surgeries, one of them is called this partial closure of the nasal orifice. This surgery is called modified Young's operation. Isn't it? If you completely close, then it is called, yes, Ganesh, you are right. This is modified Young's operation. Very good, Ganesh, very good. Nikunj Aggarwal also got it correct. If you completely close the orifice, then it becomes a Young's operation, isn't it? You know this. Guys, I'll tell you, in the last few years, 3-4 exams, every exam has a question from atrophic rhinitis. They've been consistently asking question from atrophic rhinitis. So since you advise that, please read this topic. It's a simple topic, few points, but very commonly asked. So don't miss this one. Okay, atrophic rhinitis, very favorite of the present examiners, whoever they are. But we'll go to the next question. Stimulation of the external auditory canal can lead to cough due to which nerve? Auricular branch of vagus, greater auricular nerve, auricular temporal nerve, or facial nerve. Stimulation of the external auditory canal leads to cough. Which nerve? Come on, guys. Auricular branch of vagus, greater auricular, auricular temporal, or facial? Yeah, it is auricular branch of the vagus, which is also called the Arnold's nerve. Arnold's nerve, also called Elderman's nerve. Vagus. So again, now there are two things. When you stimulate the external canal, of external auditory canal, this can do two things. It can cause cough or syncope, and both are due to vagus. So remember that both are due to vagus, right? No. And the reverse can happen. Cough is due to laryngeal stimulation. Larynx gets stimulated, and that laryngeal stimulation causes coughing. Right. Next one. A 45-year female has diagnosis with benign neoplasm, and the doctor has advised us to remove that mass for which she underwent a parotid surgery. A 45-year-old diagnosed with benign neoplasm, and the doctor has advised her to get surgery for that mass for which she underwent a parotid surgery. Not a surgical landmark for parotidectomy for facial nerve. For facial nerve. Because in parotidectomy surgery, facial nerve paralysis is very common. So basically they are asking you that during parotidectomy surgery, which of the following is not a surgical landmark for facial nerve, because otherwise the facial nerve gets damaged easily. Inferior belly of the omohyoid, tragal pointer, digastric, posterior belly of the digastric, and facial nerve dissection from the peripheral branch. So which is not the landmark for facial nerve during parotidectomy surgery? That's the basic question. Inferior belly of the omohyoid, tragal pointer, digastric, posterior belly of the digastric, and facial nerve dissection from the peripheral branch. A. See, the parotid gland is here. If I draw the face, isn't it? Parotid gland is somewhere here. This is a parotid gland through which the facial nerve comes out. It's located here, just below the ear, isn't it? The pinna, let's say, is here, and omohyoid inferior belly is below the hyoid bone. The hyoid is somewhere here, So inferior belly of the omohyoid is below this. So how can a surgery in this area cause damage to a muscle here can serve as a landmark for a surgery which is being done in this area, isn't it? That's why this is the correct answer. This is not the landmark. So tracheal pointer is a landmark. Posterior belly of the digastric is a landmark. Facial nerve from the peripheral branches is a landmark. Then few others landmarks, like you also have styloid process, then tympanomastoid suture, these are the other landmarks for facial nerve during parotidectomy surgery. So can you please explain why the tracheal pointer is it the same as tragus of the ear? Yes, it is the same as the, if you look at the tragus of the ear from the side view, the tragus on cut section, if you cut the ear like this at the tragus is not round like this. So this is again, let's say, let me draw it here. Let's say this is the pinna, and like I said, the parotid gland is this. This is your parotid gland. So if you remove this pinna and then you look at the tragus cartilage, the tragus is pointing like this. This is the shape of the tragus. So this tragus is as if it is pointing towards the facial nerve. If you go 1 centimeter towards the direction of this point of the tragus, you will encounter the facial nerve. 1 centimeter you go from the pointer of the tragus, you will encounter the facial nerve. So as if tragus is pointing towards the facial nerve. So that's why it's called tracheal pointer. It is very much the tragus cartilage. You are absolutely right. Inner ear of human being consists of 3 parts: cochlea, vestibule, and the semicircular canal. Which is saccule, or which part of the vestibule develops some? The question is, they are asking you saccule. See, inner ear consists of cochlea, vestibule, and canals. Vestibule has saccule and utricle, isn't it? They are asking you saccule. There should not have been a full stop here. Saccule develops on which part of the vestibule? Saccule, which is part of the vestibule, develops on which of the following? Saccus anterioris, saccus posterior, pars superior, pars inferior. So basically a simple question is that saccule of the cochlea of the inner ear develops on which of this? Saccule of the cochlea develops on which of this? Saccus anterior, saccus posterior, pars superior, or pars inferior? What is your answer? Saccule develops on pars inferior. Now saccus anterior and saccus posterior, saccus as the name tells is sac. In the anterior part of the middle ear there is a sac called saccus anterior. In the posterior part there is a sac called saccus posterior, and these sacs they develop spaces in the middle ear. These are spaces in the middle ear. Now inner ear which is labyrinth develops from what is called otic placard, or you can say otic vesicle. Okay, otic vesicle, otic placard has 2 parts: pars superior and pars inferior. Pars superior give rise to utricle, canals, canals means semicircular canals, and endolymphatic duct. These are the 3 things that develop from the pars superior, and pars inferior give rise to cochlea and saccule. So clearly, so saccule develops from pars inferior, isn't it? So easy. This was the basic question, and like I said, saccus anterior and saccus posterior do not develop into the parts. They are middle ear structures. They are not in the inner ear. This is about inner ear. Next question. A child with history of severe pain in the throat, with hoarseness of voice, with high grade fever and toxic look, presented with clinical condition as is shown in the image. Likely diagnosis, you can see the image there. You can see the oropharynx and there is a membrane here. The membrane is thick, is quite well defined margins. Is it membranous tonsillitis, follicular tonsillitis, diphtheria or aphthous ulcer? Yes, this is, even if you cannot identify the image, the very important hint is toxic look. If the patient has toxic look, then you will have an infection which produces toxins, and diphtheria is the only important major pathogen that produces toxins. The rest of them, they do not produce toxin, and the child does not have a toxic, very sick look. So this is clearly diphtheria. Yes, everybody got it right. The next one, name the maneuver shown in the image. Again, a straightforward question asked last time. So what maneuver is shown in this image? Is it Band Dohoff maneuver, Appley's maneuver, Foster's or Simon's maneuver? Now, all these maneuvers are done for diagnosis of for treatment of BPPV. They are mainly done for treatment of BPPV, and this way it is cyclical. Patient is made to lie down and the head turns. This is very clearly an Appley's maneuver. There is very subtle difference between these maneuvers. It's very difficult unless you see the images, but the only one they ever ask is Appley's maneuver. The rest of the maneuvers they will not ask. They may ask you disc Hallpike, but disc Hallpike is a diagnostic maneuver. It's a very different from here, but for treatment of BPPV, the only maneuver they ask you is Appley's, if they give you the image, that is. Okay. A patient presented with following picture of tympanic membrane, probable diagnosis: tuberculosis of otitis media, syphilitic otitis media, Pseudomonas infection, and fungal otitis media. So what is your answer, guys? You can see the image of a tympanic membrane, and yes, Avinash, Dix Hallpike has only 2 steps. You are right, only 2 images. It's not repeated. Yes, we just discussed this one, isn't it? There are multiple perforations. You can see all these are perforations. So these are tympanic membrane with multiple perforations, and we all know that tympanic membrane with multiple perforation is a feature of tuberculosis. We just discussed. Pseudomonas causes CSUM. In CSUM there is a single large perforation, and fungal otitis media will also cause, rest of them they will all cause single perforations. They may be central, they may not be central, but they will have single perforation. This tuberculosis is the only one that causes multiple perforation. Yes, absolutely Ganesh, you are right, spot on, that in tuberculosis, as we discussed, multiple perforation plus pale granulations, isn't it? You can't see granulations in this, cannot make out at least, but you can see the perforations very, very clearly. Tuberculosis. Inspiratory stridor is found in which kind of lesion? Supraglottic, glottic, tracheal or bronchial? Inspiratory stridor is found in which kind of lesions? Supraglottic, subglottic, tracheal or bronchus? Inspiratory stridor means stridor only when the patient breathes in. There is no stridor when the patient breathes out. Yeah, supraglottis. I'll answer your question, Avinash. I'll answer your question. Whitish patch we are talking about. So when I draw the larynx, this is how we draw the larynx on a AP view. This is a line diagram of the larynx. Okay. And we divide the larynx into 3 parts by drawing 2 lines. This part of the larynx is supraglottis. This part is the glottis. And this is subglottis. Any disease in the supraglottis causes inspiratory stridor. So this is the question, and this is what most of you have said: inspiratory stridor, supraglottis. In subglottis, it is mainly expiratory stridor, but maybe biphasic also. Biphasic means both inspiration and expiration, and glottic disease causes biphasic stridor. So this is how you remember. Supraglottis is inspiratory, glottis is biphasic, subglottis is mainly expiratory, but maybe biphasic also. Right. So before we go to the next question, you're asking about this patch, this whitish patch, isn't it? It's a very good observation, very nice observation. This looks very different from rest of the tympanic membrane, and this is due to deposition of calcium and hyaline, and this condition is called tympanosclerosis. Tympanosclerotic patch. So this is a tympanosclerotic patch which is due to deposition of calcium and hyaline, and this is a sequel of otitis media. After otitis media try to heal, it can cause this kind of a finding, and the finding is described as chalky white tympanic. What is the finding called? Chalk like white tympanic membrane. So chalky white tympanic membrane, or you can say chalk like white tympanic membrane. Right? Now tympanic membrane color, pearly white, some books say gray, is normal tympanic membrane. Okay. Red is ASOM. Blue is Gluyere, as well as, this is very important, cholesterol granuloma. Cholesterol granuloma is also called hemotympana. Hemo is blood, tympanum is middle ear. Blood in the middle ear for all long duration of time causes cholesterol formation, and that causes blue tympanic membrane. Pink tympanic membrane is autospongiosis. Active stage of autosclerosis is called autospongiosis, where you have pink blush, flamingo pink blush, Schwartz sign it's called, I'm sure you know this, and chalky white. Chalky white, I just told you, is tympanosclerosis. So these are some of the colors of the tympanic membrane. If you want to note down, they can really help you in not only identifying the image, they can also help you make a diagnosis. If there is a clinical description of the tympanic membrane, they give a clinical history, they are trying to describe the tympanic membrane, then you can pick one of these, right? Okay. The most common site of branchial cyst is posterior border of the sternocleidomastoid, anterior border of the sternocleidomastoid, digastric muscle, and omohyoid. So digastric is straightway out, because if they are mention digastric, they have to mention which belly, posterior belly or anterior belly, isn't it? You can't assume any. So if they write digastric, it cannot be a correct answer. So that is logically out. What is your question, Nikunj? What type of hearing loss could be seen in tuberculosis of the middle ear? I'll answer that question. Let me finish. What kind of hearing loss? Okay. I'm sure you know that branchial cyst is a congenital anomaly of branchial arch, isn't it? The congenital anomaly of the branchial arch, and it is seen on the anterior border of the sternocleidomastoid muscle. Anterior border of the sternocleidomastoid. It's here in a small child. And branchial arch anomalies can be a sinus, a fistula, or a cyst. Any of the three is possible in the similar area. It is around this, between the pinna and the sternocleido. It is somewhere here on the line of the anterior border of the sternocleidomastoid muscle, right? So before we go to the next question, let us answer. Then in tuberculosis of the middle ear, see, Nikunj, your question is, what type of hearing loss could you see if the tuberculosis of the middle ear? Now, if it is middle ear, it has to be conductive hearing loss, whether it is tuberculosis or anything, isn't it? Again, I'll draw pinna, canal, tympanic membrane, middle ear with 3 ossicles, inner ear, which is the cochlea and the vestibule, and 8th nerve. And if you divide this ear here, if you divide it here, this disease always cause conductive hearing loss, and this area disease always cause sensory neural hearing loss. So it is not about the disease, it is about the area it is involved. So never try to think कि कौन सा disease में कौन सा hearing loss होगा. It's not about the disease. What part of the ear is involved by the disease? If it is middle ear, whether it is tuberculosis, otitis media, otosclerosis, glomus tumor, trauma, ocular damage, anything, it has to be CHA. Straight away. Okay. Unless if TB from the middle ear goes to the inner ear, then of course it will be sensory neural hearing loss. But that has to be inner ear involved. But you clearly mentioned middle ear में है तो middle ear में तो CHL होगा. In SNHL there is one exception. That inner ear disease causing SNHL, there is one exception. Which one? Can you tell me? One exception where it is inner ear disease, but it is causing sensory neural hearing loss. It is causing conductive hearing loss. Superior canal dehiscent syndrome. Superior canal dehiscent syndrome. See, the name tells you it is a disease of the superior canal. Superior canal is a part of inner ear, but it causes conductive hearing loss. So this is an exception. Otherwise, this rule applies to every disease. Yes, I'm glad you know, guys know, at least Avinash knows the correct answer of this point. Right? Okay. Next one. Identify the lesion of the vocal cord in the image given below. Is it Wrinkle's edema? This is vocal cord. It's written here. So in case you cannot identify the structure, it is vocal cord. Laryngeal papilloma, malignancy, tracheomalacia. It cannot be tracheomalacia because this is not trachea. You can't see the trachea. Isn't it? You can't see the trachea, so it cannot be tracheomalacia. The rest of the three are possible. And yes, this is papillomatous growth. Can you see there are multiple papillomas? These are all multiple papillomas. So they are laryngeal papilloma. They are multiple papilloma. They are also called multiple papilloma of the larynx, also called JORRP. JORRP stands for juvenile onset recurrent respiratory papillomatosis. The most important question from this disease that they ask in the exam is which virus, human papilloma virus 6 and 11. This is the most popular question they ask you from this disease. Which virus causes this disease? Wrinkle's edema, on the other hand, looks like water balloon. Water filled balloon. This is how they look in Wrinkle. Obviously, edema means what? there is a water collection in the vocal cord. So obviously it looks like a balloon filled with water. Malignancy is proliferative growth. Proliferative and ulcerative growth. There is ulceration and proliferation. And tracheomalacia, like I said, is in the trachea. Trachea is weak, usually after trauma. Due to trauma or surgery on the trachea becomes weak and collapses. That wall of the trachea becomes weak and they collapse, and that's called tracheomalacia. Okay. Next one. High tracheostomy is done in a patient with consideration of the following in future: diphtherial infection, carcinoma larynx, papillomatosis, or vocal polyps. This is a straightforward question. Basically, high tracheostomy is done for which are the following conditions: diphtheria, carcinoma of larynx, papillomatosis, or vocal polyp. In vocal polyp, tracheostomy is not required, never required, almost never. Papillomatosis, usually not required, usually, very rarely. Diphtheria is a very uncommon disease nowadays. Diphtheria is a very uncommon nowadays because we have been very successful in eradicating diphtheria, not eradicating completely, but to a large extent because of very aggressive immunization against diphtheria. So yes, the correct answer is carcinoma larynx. Now, preferred site for tracheostomy is ring 2 and ring 3, but in CA larynx you can do in ring 1. In CA larynx you can do tracheostomy in ring 1, and because ring 1 is higher than ring 2, that's why this tracheostomy is called high tracheostomy. Now, some people assume that if you have to do a tracheostomy for carcinoma larynx, it is always done at ring 1. That means it is always high tracheostomy. No, it is not. In carcinoma larynx also, we prefer to do same area, ring 2 and ring 3. Same thing. But in CA larynx, we may do high tracheostomy if it is required. We may consider it. It is not always done. Welcome, Upendra Pathak, late but nonetheless. Okay, so keep that in mind. So some people make an assumption that because we keep saying that in high tracheostomy is done in carcinoma larynx, people assume that in carcinoma larynx you only have to do high tracheostomy. No, that is not true. You can do the normal tracheostomy also, but high is the may be considered, and there is no other disease where high is done except carcinoma larynx. That's what it means. Okay, stimulation of the auditory brainstem implant is placed. Stimulator of the auditory brainstem implant is placed in A. Recess of the fourth ventricle, scala tympani, oval window, external auditory canal. The choices are not good, and therefore you will be able to pick up. The choices should have been better. These are very simple choices. So even if you don't know the answer, if you use your logic, you can crack this question. So there are some questions where you may not know, but if you use your logic, your common sense, medical sense, then you can crack the answer. So first of all, I'm waiting for your answers, and then maybe I'll give you the correct answer. Yeah, see, brainstem. It's a brainstem implant, so the electrode has to go to the brainstem. The only part of the brainstem in this choices is A. Recess of the fourth ventricle is the only part which is related to the brainstem. Scala tympani is in the cochlea, and oval window is in middle ear, isn't it? And external canal is external ear. So obviously, like I said, that's why I said that even if you don't know the answer, you'll be able to answer this question. So not surprised that everybody got it right. Yes, cochlear implant is electrode of cochlear implant is inserted in scala tympani through round window. It's not exactly through round window, but this is what we say. Although technically it is not through round window, but that's what we say. It is accepted when you say this. Right. Next one. Which of the following is the tensor of the vocal cord? Very straightforward, simplest question asked last year. This is last year's question. Posterior cricoarytenoid, lateral cricoarytenoid, thyroarytenoid, and this was AIMS question, INICET. This was asked in INICET exam last year. Nobody will get this wrong, isn't it? What? Avinash, which is the main tensor? This should have asked, isn't it? So obviously cricothyroid is the main tensor. So everybody got it right. This is the only abductor. This is the only abductor, right? And these are main adductors. And cricothyroid is a main tensor and weak adductor also, isn't it? Dharani Thakur, how do we implant in this case? I think you are talking about the brainstem implant. I'm assuming that. We do a surgery. We have to open up the skull, go to the brainstem, and we go directly. You don't have to go through the ear also. You can go directly from outside, because ear has nothing to do with this now. You don't have to use you can go from outside and implant it directly from the outside. Tensor and weak adductor, yes. Cricothyroid, you are right, absolutely. Asim Mohammed. And cricothyroid pulls the cricothyroid down. Ganesh, you are wrong. When you say that cricothyroid muscle pulls the cricoid down, that sentence is wrong. Okay, it does not pull the cricoid down, thyroid down. It turns the thyroid. So thyroid, suppose this is a thyroid cartilage, my hands. Pulling down means what? Pulling down means it pulls down. No, it doesn't pull down. If it pulls down, how will it tense? You have to pull it. So what it does is it turns the thyroid cartilage like this. Thyroid cartilage angle forward. The face of the thyroid cartilage is turned anteriorly and inferiorly. It's not down only, it is anterior and inferior. It's turned like this. It turns like this, turns. It is not down, it turns like this. So when it turns anterior inferiorly, it pulls the vocal cord, and that makes it tight or tense. Okay, so please make that correction in your concept. It is not pulling it down, it is turning. It is not pulling, it is turning, and it is not down, it is anteriorly and inferiorly. Okay, correct. Now you are right. Now you are right. Okay, most common fungus causing orbital cellulitis in diabetic patient. So, which is the most dangerous fungus of the ear, of the sinus, which can spread to the orbit and cause? So, in this, both these are correct answers, because both the disease causes what is called mucormycosis. And this is slightly controversial. From a name, if you go for mucormycosis, it appears mucor is the most common fungus causing mucormycosis, and therefore this would be the correct answer. It is given in some books, yes, but this is not the correct answer. The correct answer is Rhizopus. Rhizopus is the most common fungus causing mucormycosis, although the name comes after mucor, but Rhizopus is more common than mucor. Both can cause mucormycosis, like I said, but Rhizopus is a better answer when they ask you which is the most common fungus causing mucormycosis, and this causes orbital cellulitis also. But mucor is not a wrong answer. It is nearly, both are nearly correct. They are almost there, both of them. But if you have to pick, if rhizopus is not given, then you can go for mucor, correct. But if rhizopus is given, then you have to go for rhizopus. Mucor is also correct answer. This is we are assuming from the orbit. This is a complication of sinusitis. This is as a result of complication of sinusitis. I'm assuming this. Right. Okay. So B is the correct answer. So if you have got it wrong, so many of you got it wrong, I don't mind, because the name is misleading, and mucor is not 100% wrong answer. Almost it is there, almost equal. Both are almost equal. This we have done. So you know what is Waters view, but you have to know it is used for maxillary sinus, frontal sinus, sphenoid sinus, mastoid air cells. So Waters view is used for which of the following sinuses? Maxillary sinus, frontal sinus, sphenoid sinus, or mastoid air cells? Yes, maxillary sinus, isn't it? A. For maxillary sinus, we can do Waters view. We can also do Peerage view. If Waters is not given, Peerage is accepted, because both are occipitomental view or mento-occipital view. For frontal sinus, we do Cardwell's view. This was also asked last to last year. For sphenoid sinus, you can do Peerage view, this one, and you can do basal view. Basal view is sometimes called Hitz view. Basal view is Hitz view. And for mastoid, you have Schuller's view and Townes view. Actually, this will cover all the important X-ray views and what you see from the ENT point of view. These are the only important X-rays that they ever ask. They don't go beyond this. So this covers all pretty much every X-rays that you have to know from the ENT point of view. But remember, in mastoid we do two views. Cells doesn't matter. Cells doesn't matter. Just stick on सिलेंडर सेलेस. लेट्स स्टिक ऑन. आपको पता चलेगा कि आगे आप जगह अगर डॉक्टर बन जाएंगे तो आगे कैसे क्वेश्चन आएंगे. एंड कई बार लॉट ऑफ क्वेश्चंस दे गेट आस्क्ड फ्रॉम द बेसिक क्वेश्चंस फ्रॉम द एमबीबीएस लेवल भी कई बार पूछ लेते हैं. जैसे व्हाट एक्सरे व्यू हो सकता है कि आपसे पूछ ले. सो नेवर माइंड, सिंस यू हैव जॉइंड, वेलकम, यू आर मोस्ट वेलकम, एंड जस्ट सिट अलोंग एंड जस्ट सी, हैव फन इफ नथिंग एल्स. देखो तो सही, डॉक्टर बनोगे आगे चल के तो किस तरह के क्वेश्चन आएंगे और कैसे आपको पढ़ाई करनी पड़ेगी. एटलीस्ट दैट मच यू विल नो, है ना. ट्रेकियोस्टोमी इज इंडिकेटेड इन ऑल एक्सेप्ट. सेलेस, डू यू नो व्हाट इज ट्रेकियोस्टोमी का मतलब क्या होता है? ट्रेकियोस्टोमी, यू नो ट्रेकिया, है ना, मेकिंग अ ओपनिंग इन द ट्रेकिया. ट्रेकिया में छेद बनाते हैं, मेक अ ओपनिंग इन द ट्रेकिया, एंड द आइडिया टू बाईपास द लैरिंग्स. Larynx, we breathe from the larynx, and the air from the larynx goes to the trachea to the lungs. So if your larynx is blocked due to anything, so larynx से सांस नहीं जाएगी, you can't breathe, so bypass करना पड़ता है. So we make an opening in the trachea, and the surgery is called tracheostomy. This is especially for Cellis if he is still around. So it is indicated in all except. This is 2 years old question, and this is slight, or not 2, this is 3 or 4 years old question, and I can understand that this is slightly maybe difficult for you. Vocal cord replacement, pharyngeal replacement, tracheomalacia, and foreign body obstruction airway. So what is your correct answer? Ganesh says B, Asim says C, Tej B, Target Ames B, Okay, tell me, which is the most common site of foreign body in airway? Most common site of foreign body in airway is right main bronchus, and very common site is larynx. Okay, just hold on. Okay, the most common site of foreign body in the airway is right main bronchus or larynx. Now, if this is the larynx, this is your thyroid, there is no space, so I am just, okay, this is your larynx, and then there are tracheal rings, lot of tracheal rings, trachea, then divided into bronchus, isn't it? Now, tracheostomy is an opening which is made here. If the foreign body is in the right main bronchus, this is your foreign body. This patient has no emergency. Why? Because you can still breathe from the left side. Normally, with one lungs, you can survive the whole life. There is no emergency. So if there is no emergency, there is no obstruction, serious obstruction. There may be slight problem, but it's no obstruction. So why will you do tracheostomy? Okay? You will not do tracheostomy. If larynx is obstructed, if the foreign body is in larynx, if the larynx is completely blocked, will this patient be able to reach hospital alive? If your airway is completely blocked, this patient cannot survive for more than 2 minutes. Isn't it? Hospital पहुंचेगा ही नहीं जिंदा. He will die before the patient, even at home the patient will die. जहाँ पे foreign body. So there is no question of tracheostomy. And if this patient of laryngeal obstruction reaches the hospital alive, जिंदा hospital पहुंच गया, 15-20 मिनट लग गए उसको पहुंचने में, that means it is not completely obstructed. It is partially obstructed. The patient is able to breathe. If the patient is able to breathe and is able to survive 15 minutes, 20 minutes, then why do tracheostomy at all? Foreign body निकालने में ध्यान दो ना. Tracheostomy में why do you are wasting time doing tracheostomy? Use your effort to remove the foreign body from the larynx. So again you will not do tracheostomy. Okay. So what I am trying to say is, if foreign body goes to main bronchus, then the patient does not need tracheostomy because the left side is normal, and with left normal bronchus and lungs, one can survive the whole life with one lungs. So no tracheostomy required. If it is in the larynx, if the larynx is completely obstructed, then the patient will not be alive by the time it comes to you. So there is no question of tracheostomy. If the patient has reached you alive, that means it's not completely blocked, it is partially blocked. The patient is able to breathe. If the patient is able to breathe through the larynx, why do a tracheostomy at all? And therefore, this is your correct answer. I hope that explains. Yeah, beyond the trachea, Ganesh, you are right, beyond the trachea, but we have discussed that bronchus. It can go to the bronchus, but if it goes to the right main bronchus, which is the most common site, then you will not do tracheostomy. And even if it is here, if it is struck here, foreign body, and causing complete obstruction, tracheostomy क्या उखाड़ लेगा? This, you make an opening here, यहाँ से भी जो हवा जाएगी सांस, it is still getting obstructed here, isn't it? Getting the point? Even then, tracheostomy, in foreign body tracheostomy is a foreign body of the airway, tracheostomy is the waste of time, useless thing, we don't do it. So even if you don't know all this, you can answer this question. I hope that clarifies a lot of points. Okay, structure not removed in radical neck dissection is a straightforward question. This is discussed mainly in surgery but also in ENT, that in radical neck dissection we remove 1 to 5 groups of lymph nodes and 3 structures, and the 3 structures are sternocleidomastoid muscle, 11th nerve and jugular vein, isn't it? So obviously we don't remove the digastric muscles. We don't remove the digastric muscle. Avinash is asking, in tracheomalacia, I told you, remember tracheomalacia is weakening of the tracheal ring. The tracheal ring becomes weak, so they tend to collapse. When they collapse, they will cause the obstruction. So if you put a tracheostomy tube inside, then the tracheal ring which are weak will not collapse. They will not cause the obstruction, and through the tracheostomy the person can breathe. And it is never a permanent solution. It is a temporary solution till you do something permanent about the tracheomalacia. When tracheomalacia, you have to do something permanently. We have to do surgery and remove that part of the trachea or whatever. Depends on many factors. Grading होती है उसमें, grading के भी depend करता है. But initially when the tracheomalacia, the trachea becomes weak, it tends to collapse. You put a tracheostomy tube, it prevents the collapse of the trachea and cause the obstruction. That's how it prevents. Okay. A patient underwent lateral skull base surgery few months back and has presented with complaint of recurrent aspiration. There is no change in voice of the patient. Which of the following nerve is most likely to be injured during surgery? It is bilateral recurrent laryngeal nerve. If you have attended my lecture, you will know this very clearly, that when there is a laryngeal vocal cord palsy, damage to the vocal cord, the symptoms of aspiration, weak voice, hoarseness, and dyspnea. This is dyspnea. Cyanosis is because of dyspnea. These two are due to recurrent laryngeal nerve damage. Weak voice is due to external laryngeal nerve or superior laryngeal nerve, and aspiration is due to internal laryngeal nerve. I explained this very nicely, very detailed in lecture in the class. If you have attended that, you will know this very nicely. Even you can watch the app, eGurukul app, to get this one. Okay, there are two questions. There is one question. Okay, Cylinder, Celeste, all the best. Best of luck for your UG exam. Superior semicircular canal dehiscent syndrome is associated with all except. I discussed superior canal dehiscent syndrome. I told you the name of this. There is dehiscence of the superior canal, and which is not a feature of this. Gaze dependent nystagmus, positive Toulouse phenomena, positive fistula test, and sensory neural hearing loss. Remember, I told you that superior canal dehiscent syndrome has conductive hearing loss, isn't it? It has a conductive hearing loss, and so it will not have a sensory neural hearing loss. Straight away. All are feature of superior canal dehiscent syndrome except superior sensory neural hearing loss. We have discussed this. A young man with history of ear infection presents with a smooth erythematous swelling in the mastoid process. Which is the most likely diagnosis? Agar smooth erythematous swelling, this is called ironed out mastoid. This finding is described as ironed out mastoid. And obviously ironed out mastoid is a feature of mastoiditis. In rest of them, mastoid has no problem. In all this, there is nothing in, no mastoid finding in all of them, except ironed out mastoid is acute mastoiditis, Graysinger sign, edema. Remember, edema of the mastoid is Graysinger sign, and blue color of the mastoid is Battle sign. This we have seen. This is Graysinger's. So these are the three findings in the mastoid. You know this, all of them. A patient presented to the OPD with complaint of rotatory vertigo and nausea in the morning on change of position of the head. What is your diagnosis? So this is positional vertigo. This is positional vertigo. On changing the head position, the patient has vertigo and nausea, and we all know positional vertigo is a feature of BPPV. The name tells you benign paroxysmal positional vertigo. The P stands for the word positional, and we all know this. BPPV. A 16-year-old male complains of nasal obstruction, nasal blockade. A mass is seen in the nasopharynx with minimal extension into the sphenoid sinus. What is the stage of nasopharyngeal fibroma? Now, this is a bad question, because in nasopharyngeal angiofibroma, this is nasopharyngeal angiofibroma, a 16-year-old juvenile, and in this there are 5 classifications. 5. Now, which classification are they talking about? We have to mention, because each classification is different, and this is perhaps a Sessions classification. In Sessions classification, when it goes to the sphenoid sinus, minimal invasive, it is 1B. It is 1B, but this is a bad question. They have to name the classification that you have to use to stage, and it's not a good question. They don't ask you very often, so just ignore this question. It was asked, I think. In superior nerve aspiration, Kunj, in superior laryngeal nerve, there are two things. There is aspiration plus there is weak voice, both. So yes, aspiration is there. That's true. Why is recurrent palsy abductor and vagus palsy adductor? According to Sessions, it is 2A. You are right. According to Sessions, it is 2. Did I say? Yeah. Please make a correction. 2A. Sessions is 2A. Let me answer this question. Asim is asking me, why is recurrent called abductor and this is Parag for you. See, Asim, I'm answering your question. See, vocal cord is like this. Adductors are pulling the vocal cord inside. Abductors are pulling the vocal cord outside. Okay. Now, if this is caused by recurrent laryngeal nerve, if recurrent laryngeal nerve is paralyzed, cricothyroid is still functioning. Cricothyroid is still functioning. And what is the function of cricothyroid? Cricothyroid is a weak adductor. So cricothyroid does weak adduction. So weak adduction is possible, but abduction is not possible. Abduction is not possible. That's why recurrent laryngeal nerve palsy is called the abductor palsy. And when the vagus is gone, then all the movement is gone. The most important movement we need in the vocal cord is adduction. Adduction is the most important movement we need in the vocal cord for voice production, and therefore when the vagus palsy is gone, the adduction, the main movement is gone. That's why it's called adductor palsy. That's the logic behind all these things. Parag Naik, no aspiration. I don't know you, Parag, I did not get your question. You are talking about aspiration. What is it about? Avinash. If there is bilateral recurrent palsy, the vocal cord will not adduct and not abduct. Yes, you are right. When the vagus is palsy, it will not adduct, it will not abduct, nothing will happen. But because we need adduction, our main movement is adduction, and that adduction is gone. That's why it is called adductor palsy. The main movement is gone. We are talking about main movement. But in recurrent nerve palsy, adduction is there. Abduction is not there at all. So that's why it's called abductor palsy. That's the whole logic behind this names. See, I'll talk about nerve. See, for those who have questions, doubt about vagus palsy. Vagus in the larynx supplied via two branches. One is superior laryngeal nerve, one is recurrent laryngeal nerve. Superior divides into internal laryngeal nerve and external laryngeal nerve, and recurrent remains recurrent laryngeal nerve. So ultimately in the larynx we have three nerves. Okay, if this is gone, the main symptom is aspiration. Only the main symptom. If this is gone, the main symptom is weak voice. If this is gone, either it is hoarseness or dyspnea, difficulty in breathing, stridor, whatever you want to call it, cyanosis. So in the question it was about cyanosis, dyspnea. Therefore recurrent is the correct answer. If hoarseness is given, again recurrent is the correct answer. If only weak voice, if the choice says the only complaint is weak voice, then external is gone. Okay. If the only complaint is aspiration, then internal is gone. Right. If the patient has both these symptoms are possible when this is gone. Superior through this causes aspiration, through this causes weakness. So depending on what combination of symptoms are given in the choices in the question, based on that you can pick up. So if you remember this particular flow chart, depending on which of the 4 symptoms are given, you can pick the correct nerve in that case. So this is what I teach in the lecture in details properly, so you get to understand. When you go step by step, it becomes easy to understand. So Parag, I think this answers your question. If you have any questions. No, I did not mark by. The question did not say aspiration. Oh, okay, aspiration. Okay. I thought it's talking about dyspnea, cyanosis. Actually, the question which was asked in the exam had cyanosis, not aspiration. So that was playing in my mind. You are right. Thanks for clarifying, correcting me, Parag. You are right. So there is aspiration here, and that's why, as you know, that if it is aspiration, either superior or internal, isn't it? One of the two has to be the correct answer. Internal is not given, and therefore aspiration is the correct answer. Thank you, Parag. Thank you so much. I read it cyanosis. That's why I was talking about cyanosis. If there is cyanosis, then recurrent is gone. But if you keep this one in mind, this very beautifully tells you whatever you need to know. Right? So this is the choice. So either this is gone or this is gone. Since this is not giving the choices, you have to be this one is the correct answer. In vagus palsy, you will have more than one symptom. You will have one of this and one of this at least. So one of this and one of this. If you have this combination, then it has to be vagus. That's how you pick up. So guys, I think this is all we had time for. We have exceeded our time limit, but doesn't matter anything for you. But I hope this session was useful. Clarifies a lot of your points, and you get a lot of stimulus to read ENT again. So hope to see you on the other side of the exam, where we'll celebrate when you clear the exam. So all the best, guys. Best of luck. Please keep working. There's no time left for any other things. The only trick to clear the exam is keep studying, keep revising, keep revising. Don't read new topics, don't read new subjects. Whatever you read, just keep revising them. There's no time to do new stuff. Revise and solve MCQs, attend these kind of sessions, and there's no reason you'll not do very well. So best of luck. Take a very good care of yourselves. Goodbye, guys.